IDF. الدكتور مجدي not only a speaker or a professor of medicine لكنه فعلا معلم. مرحبا بك دكتور مجدي، تفضل.
السلام عليكم، متشكر جدا على التقدمة التي لا أستحقها، بس ده كرم كبير من حضرتك. دايما بأسعد وأشرف بوجودي مع أصدقائي وأهلي من اليمن الشقيق. حقيقي فخور وسعيد أني معاكم النهاردة. وفي الدقائق القادمة أنا عايز أفوكس على احنا في الera of combination in the management of type 2 diabetes. There is no longer a monotherapy for a patient with type 2. Whenever we diagnose type 2 diabetes, we start with combination, and we're gonna see what is the rationale behind that. But today I'm focusing more on a combination of SGLT2 inhibitor and DPP4 inhibitor. SPC stands for single pill combination. The ADA for this year, we can summarize this algorithm. I'm sure that you have seen it several or many times. The summary, the theme of this algorithm is that one size cannot fit all. I mean, you cannot say that, well, this drug is appropriate for all people with type 2 diabetes. No, we tailor therapy according to the characteristics of the patient or the patient profile, meaning the patient's age, comorbidities, weight, lifestyle, other complications of diabetes, vascular complication, whether micro or macrovascular. You can decide which drug for whom. So let me take you navigating 3 or 4 case profiles and see how to fit the treatment or the drug regimen to the patient profile. نبدأ بالأستاذة كريمة. الأستاذة كريمة، وأول كلمة قالتها الأستاذة كريمة لما شفتها في العيادة، قالت: أنا لا أحب الأدوية الكثيرة. أرجوك لا تكثر من عدد الأدوية. الأستاذة كريمة مدرسة عمرها 52 سنة. She's having type 2 diabetes since 4 years. BMI 27, she is a bit overweight. Recently, she had myocardial infarction, عملت PCI and insertion of stents for this MI, acute coronary syndrome, managed by primary intervention. She is having a stable heart failure with ejection fraction of 36, the so-called heart failure with reduced ejection fraction. الأستاذة كريمة عندها history of metformin intolerance. 1 in every 7 to 10 people do not tolerate metformin. I mean, GIT upset occurs with the first dose of metformin. She is having GIT intolerance to metformin. That's why she is on linagliptin, DPP4 inhibitor, 5 milligram a day. Albumin creatinine ratio is less than 30. She is not having chronic kidney disease. And the blood glucose is a bit high, A1C 7.8. So again, الأستاذة كريمة التي لا تحب الأدوية الكثيرة، مدرسة عمرها 52 سنة. She is having cardiovascular disease. She is having heart failure with reduced ejection fraction with no chronic kidney disease. The blood glucose is uncontrolled on monotherapy of linagliptin 5 milligram a day. And she is concerned about heart disease. And actually, she should be concerned, and we should be concerned too, because we know very well that 8 out of 10 individuals with diabetes died due to cardiovascular disease. So everyone should be concerned about heart disease of الأستاذة كريمة وكل كريم. What to do? She is now on linagliptin, DPP4 inhibitor, 5 ملغ في اليوم, and the blood glucose is uncontrolled. Let's go to the ADA 2023 and see the place for الأستاذة كريمة, how to tailor treatment للأستاذة كريمة. الأستاذة كريمة is having atherosclerotic cardiovascular disease. والguidelines بتقول لنا اللي عنده atherosclerotic cardiovascular disease should be either on GLP-1 receptor agonist or SGLT2 inhibitor, independent of A1C. Even if her blood glucose is controlled, she should be either on GLP-1 receptor agonist and or SGLT2 inhibitor for cardio protection based on Empagliflozin study. Empagliflozin study غيرت الجايدلاينز. Empagliflozin study كانت على أكثر من 7000 مريض في 42 دولة. Like الأستاذة كريمة, type 2 diabetic patients with cardiovascular disease. Randomized إلى Empagliflozin versus placebo with a mean follow-up of 3.1 years. وما حدث في الإمباريج كان عجيبا. Significant reduction of 3-point MACE, 38% reduction of cardiovascular death, 35% reduction of hospitalization of heart failure, and decrease of all-cause mortality by 32%. And based on the results of the Empagliflozin outcome study, SGLT2 inhibitors are indicated for patients with cardiovascular disease regardless of A1C level. لكن الأستاذة كريمة مش بس عندها atherosclerotic cardiovascular disease, لكن دي عندها heart failure. So back to the algorithm, if your patient is having heart failure, he or she should be on SGLT2 inhibitor بلا منافس في الحتة دي. يعني في الاتروسكليروتيك cardiovascular disease يتنافس أو يتعاون ال SGLT2 inhibitor مع GLP-1 receptor agonist. في الهارت failure SGLT2 inhibitor should be there in every patient with heart failure based على Empero reduced trial. Empero reduced trial دي كانت double blind study on patients with heart failure with reduced ejection fraction like الأستاذة كريمة with or without diabetes, randomized إلى Empagliflozin versus placebo with follow-up 16 شهر. الcombined endpoints كانت 25% less with Empagliflozin arm, and hospitalization for heart failure can 30% less in the arm of Empagliflozin. وتلا الإمبا reduced study Empero reduced study Empero preserved study. Similar design, but on patients with heart failure and the preserved ejection fraction. If the ejection fraction is more than 40%, and the results have been positive as well, with significant reduction of cardiovascular outcome in patients with heart failure with preserved ejection fraction. وعليه الأستاذة كريمة وكل كريمة أتحدث عن مريض عنده heart failure، أتحدث عن مريض عنده atherosclerotic cardiovascular disease should be on SGLT2 inhibitor, and one of the eminent SGLT2 inhibitors is Empagliflozin, so we would start with 10 milligram Empagliflozin for him. Well, looking at this point for adherence to treatment، الأستاذة كريمة لا تحب الأدوية الكثيرة، وبالتالي من أجل هذا اخترع السنجل بيل كومباينيشن أو الفيكسد دوز كومباينيشن، سميها كما تشاء، ولكن putting more than one ingredient, more than one molecule in the same pill بيحسن الادهيرنس تو treatment. وبالتالي الأستاذة كريمة already على linagliptin 5 ملغ. So one of the good ideas not to add another tablet with empagliflozin, but you can simply shift her from linagliptin 5 mg tablet to single pill combination of empagliflozin, linagliptin, 10 mg of EMPA and 5 mg of linagliptin. This would improve the patient's adherence. وهذه كانت قصة الأستاذة كريمة. نترك الأستاذة كريمة ونروح للدكتور عادل. الدكتور عادل physician سنه 52 سنة, type 2 diabetic since 2 years. الدكتور عادل is overweight, non-smoker, but having controlled hypertension. No evidence of cardiovascular disease بالنسبة للدكتور عادل. الدكتور عادل بياخد linagliptin DPP4 inhibitor with metformin 1000 ملغ twice daily. And he is having evidence of chronic kidney disease. When you find urinary albumin creatinine ratio more than 30 or GFR less than 60 or both of them together, your patient is having CKD or DKD, diabetic kidney disease, and is having non-alcoholic fatty liver disease, NAFLD or MASLD or MAFLD, whatever you want to call it. His blood glucose is high. A1C is 7.7. So we're having a type 2 diabetic patient with no evidence of cardiovascular disease, but he is having diabetic kidney disease. He is on metformin and DPP4 inhibitor. Let's go to the guidelines. The place for Dr. Adid is here. Patient with CKD. Patient with CKD should be on SGLT2 inhibitor, whatever the A1C is. So even if your patient is controlled, one should add SGLT2 inhibitor for nephroprotective effects. Based on a lot of trials and a lot of mega studies confirmed the renal benefit of empagliflozin. In the Empareg study, we have just mentioned the cardiovascular benefits. The progression of chronic kidney disease can 39% less with empagliflozin. Empero reduced trial لسه جايبين سيرتها في cardiovascular benefits. Progression of chronic kidney disease كان 50% أقل في الارم of empagliflozin. And most recently Empakidney study. Empakidney study دي كانت double blind randomized multi-center study involving حوالي 7000 patients كلهم عندهم chronic kidney disease with GFR 20 to 45% أو GFR أكتر من كده لكن albumin creatinine ratio أكتر من كده. يعني أنا دخلت هنا في الإمبا kidney study وأنا عندي chronic kidney disease whether diabetic or not. Randomized إلى empagliflozin versus placebo with follow-up وما حدث هو significant reduction 28% less progression to chronic kidney in the chronic kidney disease with the arm of empagliflozin. So Empakidney study was a primary endpoint was progression of chronic kidney disease can significantly less with empagliflozin. So starting from Empareg, مرورا بالإمبيرو reduced to Emperor preserved, ending up with Empakidney, all focus on the renoprotective effect of empagliflozin. وبالتالي بالنسبة لعادل وكل عادل يعني عيان with type 2 diabetes with diabetic kidney disease, he should be on SGLT2 inhibitor even if the blood glucose is well controlled. So you should, I'm not saying a good idea, you should add empagliflozin 10 milligram for Mr. Adi? Well, he is on linagliptin already. So again, to improve your patient's adherence to treatment, please think of single pill combination, not only in diabetes, also in hypertension, in dyslipidemia, in everywhere. If you want your patients to adhere more to treatment, you should try to reduce the number of pills your patient has to swallow every day. So it's an attractive idea here just to replace the tablet with linagliptin 5 milligram with a fixed dose combination of Empa, Lina, 10/5 tablets once daily, and keep the metformin as such. This is the story of الدكتور عادل. نروح للحاجة سميحة. الحاجة سميحة سنها 58 سنة. BMI 23. الحاجة سميحة رشيقة. مفيش هنا overweight. She is living alone, used to miss meals and medications. And for these patients, again, if you decrease the pill burden, it will be a good idea. And to avoid hypoglycemia is very important. Her serum creatinine is 1.9 with albumin creatinine ratio of 161, more than 30. So she is having chronic kidney disease with creat of 1.9. الحاجة سميحة بتاخد ميتفورمين 1000 ملغ per day. And she stopped sulfonylurea glympyride after an attack of severe hypoglycemia on 1 milligram of glimepiride. So she stopped glimepiride after this hypoglycemia. And the blood glucose is high. So again, we have a patient with type 2 diabetes with chronic kidney disease. Her creatinine is 1.9, and she stopped the sulfonylurea due to severe hypoglycemia, and she is now on monotherapy of metformin 1 gram a day. حاجة سميحة قالت لي أرجوك مش عايزة expensive drugs. Please try to add expensive drugs. And when I say expensive drugs, I think of GLP-1 receptor agonists, a genius group of drugs, but unfortunately, the cost of GLP-1 receptor agonist is a big barrier against its widespread prescription. But let me focus with you on her creat. Creat 1.9. 1.9. Well, we do not use the language of creat in our work, as you know. We use the language of eGFR. How to calculate GFR? We all know that in every patient with diabetes, we should check serum creatinine annually, and to estimate GFR using GFR calculator. Application should be on our phones. GFR calculator, very simply, you enter the patient's age, creat, you will get the GFR in 1 second. So her age is 58, her creat is 1.9, gender is female, GFR estimated is 27. 27. 27 puts here in stage 4 chronic kidney disease. We stratify our stage chronic kidney disease in 5 stages based on GFR cutoffs 90, 60, 30, 15. هي الجي اف ار بتاعها 27، هي في الحته بتاعت ستيج 4 chronic kidney disease. وهنا الكلام more precise. جي اف ار بناخد على اساسه قرارات علاجيه كثيره جدا. الجي اف ار بتاع الحاجه سميحه is 27. So how to look at metformin? Would we continue metformin or stop metformin or reduce the dose? What should we do? Well, the guidelines are clear. When the GFR gets below 30, one should stop metformin. It's absolute contraindication of metformin when the GFR falls below 30. So metformin, yes, it should be first line of treatment in type 2, but when it's contraindicated, you should think of other oral antidiabetic drugs or injectable antidiabetic drugs, these classes. SGLT2 inhibitor, DPP4 inhibitor, SU, she has been on SU and stopped due to hypoglycemia, pioglitazone, GLP-1 receptor agonists. Let's take one by one. SGLT2 inhibitor, هل هي indicated في الحاجة سميحة بالجي اف ار بتاعها اللي هو 27؟ تعالوا نبصوا بقى في الحته بتاعت السيكي دي ونكبر الحته دي. Use GLT in people with GFR 20 or more. So we start SGLT2 inhibitor عندما يكون الجي اف ار 20 or more, and once initiated it should be continued until initiation of dialysis or transplantation. أيهما أقرب؟ يبقى تاني، أي مريض diabetic kidney disease الجي اف ار بتاعه 20 أو أكتر should be on SGLT2 inhibitor. فهنا في جي اف ار 27 كريات 1.9 أحيانا بنفكر كده شوية، هل المفروض أبتدي SGLT2 inhibitor ولا لا؟ Guidelines are clear here. She should stop metformin لأن الجي اف ار أقل من 30 and start empagliflozin 10 milligram 1 tablet a day. Well, her blood glucose was still high on empagliflozin 10 milligram, and the dose of empagliflozin has been titrated up to 25 milligram once daily. And with empagliflozin 25 milligram a day, the blood glucose improved, but it's still high. The A1C is 7.9. So what to do next with a patient here with this criteria? Metformin is contraindicated, and we started SGLT2 inhibitor and titrated the dose to 25 milligram, and still blood glucose is not at the target. What to do? Let's go back here. She is on SGLT2 inhibitor. Would we think of GLP-1 receptor agonists? Actually, it might be a good idea, but the cost is an issue. So we changed our idea because she told us that, well, I do not need expensive drug. Pioglitazone, efficacy-wise, this would decrease the A1C, but safety-wise, you should think twice before starting thiazolidinediones in post-menopausal females, because this might accelerate the rate of osteoporosis. Beside weight gain, sulfonylurea, okay, she has been on SU and she has got severe hypoglycemia. That's why I stopped sulfonylurea. What about DPP4 inhibitor? Well, in these patients, DPP4 inhibitors are ideal drugs to be added. أتحدث عن safety-wise. And the only DPP4 inhibitor you do not need to make any dose adjustment is linagliptin. Linagliptin in the dose of 5 milligram a day. This dose can be prescribed in all categories of chronic kidney disease from stage 1 to stage 5. The same 5 milligram. No need for dose adjustment with linagliptin. The only DPP4 inhibitor that you do not need to modify the dose based on GFR. And the 5 milligram in all stages of chronic kidney disease will lead to similar efficacy-wise decrease of A1C. I mean, efficacy-wise and safety-wise, giving the 5 milligram of linagliptin is a good and safe options in patients with advanced chronic kidney disease. Well, your patient is now on empagliflozin 25 milligram a day. I want to add the 5 milligram of linagliptin. Again, the patient is living alone and she needs less complex anti-diabetic regimen. So one of the attractive ideas, one of the smart ideas, is to make use of single pill combination. So this tablet of empagliflozin 25 milligram can be simply replaced by a tablet of single pill combination of empagliflozin 25 milligram, linagliptin 5 milligram, still once a day. وبالتالي بالنسبة للحاجة سميحة وكل حاجة سميحة, patient with chronic kidney disease should be on SGLT2 inhibitor. Lethal blood glucose is not controlled well. Think of DPP4 inhibitor. Let's move to the last case for today. مدام رانيا. تحدثنا في الحالات السابقة عن cardiovascular disease, عن chronic kidney disease, عن advanced chronic kidney disease. مدام رانيا قصتها مختلفة. لا هي عندها cardiovascular disease ولا هي عندها chronic kidney disease. مدام رانيا مرشدة سياحية سنها 48 سنة, recently diagnosed type 2 diabetes. But her BMI is 31. She is obese. She started metformin with the lowest dose of 500 milligram a day, but GIT upset occurred. So she discontinued metformin. And she tried to start GLP-1 receptor agonist. She can afford the cost of GLP-1 receptor agonist. She is insured, but GIT intolerance occurred again. Reminding you that here we have upper GIT, nausea and vomiting, and here lower GIT, usually lower GIT like flatulence and diarrhea. And she presented to us here with A1C of 8.7. So again, Rania, type 2 diabetic patient, newly diagnosed, no cardiovascular disease, no chronic kidney disease. She is having intolerance to metformin and GLP-1 receptor agonists. She is eager to lose weight. She wants to lose weight. Her job necessitates that she should lose weight. And she is concerned about hypoglycemia. Again, her job cannot tolerate having frequent hypoglycemia while working. وبالتالي مدام رانيا المرشدة السياحية, recently diagnosed type 2 diabetic patients with no vascular complications, and عندها أمنيتين, نفسها تفقد وزن and not to get hypoglycemia. Let's go to the guidelines. This on your left hand is management of type 2 diabetic patient with vascular complications, whether micro or macrovascular. But the part on your right hand, which is fitting to Rania, is type 2 diabetic patients without evidence of cardiovascular disease or chronic kidney disease. In such a patient, metformin should be the agent of choice to start with. But Rania is having GIT intolerance to metformin. So let's look at other options we do have in the management of type 2 diabetes. Sulfonylureas, DPP4 inhibitors, thiazolidinediones, SGLT2 inhibitors, GLP-1 receptor agonists. And this table can say it clearly that الكمال لله وحده. ما فيش anti-diabetic class perfect, no perfection. كل class من دي لها advantage and disadvantage, as you see here. وبالتالي one should tailor the treatment according to the characteristics of the patient. Think of efficacy of the drug, safety of the drug, weight of the patient, risk of hypoglycemia, and cost as well. And decide which drug you want to start for your patient. Let's look at this patient specifically. She is concerned about hypoglycemia. So we can think of DPP-4 inhibitor, of thiazolidinediones, of SGLT2 inhibitor, of GLP-1 receptor agonist, but of course not of sulfonylureas. So looking at الأمنية الأولى لرانيا, she wants to avoid hypo. You can think of these 4 anti-diabetic drugs. الأمنية الأخرى, she wants to lose weight. Well, SGLT2 inhibitor or GLP-1 receptor agonist. Both classes can lead to weight loss. But she couldn't tolerate GLP-1 receptor agonist. So, and pioglitazone definitely هيحطم أمنيتها الأخرى إن هي تفقد وزن، لأن البايوجليتازون هيزود الوزن، بالظبط زي السلفونيليوريا اللي هيزود الوزن. وبالتالي we are left up with DPP-4 inhibitor and SGLT2 inhibitor. يبقى احنا هنا عندنا 2 anti-diabetic drugs fitting ينفعوا يليقوا على رانيا، وممكن ما ينفعوش غيرها. أتحدث عن tailoring therapy in the management of type 2 diabetes. والسؤال, would you start with a combination of both DPP-4 inhibitor with SGLT2 inhibitor, initial combination, or sequential add-on? You give one class, and if needed after 3 months with A1C monitoring to add the other one. And actually, the guidelines in 2023 say it clearly that combination therapy is name of the game, is the secret of success in the management of type 2. Why? The rationale that type 2 diabetes is a progressive disease. And we all know that you move from monotherapy to dual therapy to triple therapy, add insulin. So it might be a good idea that you start with a dual therapy. Number 2, multiple pathophysiological defects occurring in patients with type 2 diabetes. I mean, it's not only insulin resistance, it's not only beta cell dysfunction. We have here at least the ominous octet. So if you give the patient, for example, SGLT2 inhibitor, you are working on the kidney. With DPP-4 inhibitor or incretin therapy, you are working on alpha beta cells and incretin effects. So you are tackling more than one mechanism in the pathophysiological defects of type 2 diabetes. At last but not at least, by giving a combination in the start of type 2 diabetic patient treatment, you are trying to avoid clinical inertia. وفي عملنا جميعا بنلاقي ساعات بيجي لنا مريض with newly diagnosed type 2 and you start the treatment وينشغل المريض ويختفي المريض ولا تراه لمدة أشهر أو سنين. وبالتالي if you started with a combination, you might give the patient benefit that لو اختفى يبقى اختفى معاه combination of anti-diabetic drugs. وبالتالي في هذه المريضة بالبروفايل ده بالظروف دي بالبرزنتيشن دي, it's a good idea to start with a combination of Empagliflozin and Lingliptin in single pill combination. Well, بعد 3 شهور الامور اتحسنت قوي مع مدام رانيا. فاستنج 152, بوست برانديال 206, A1C 7.3. She is near to target with Empagliflozin 10 ملغ, Lingliptin 5 ملغ. والسؤال والديبيت, should we increase the dose of SGLT2 inhibitor from 10 mg to 25 mg, or this does not have any additional benefits? I'm saying the debate. That's why this study has been conducted, data coming from Japan. They studied the clinical benefit of switching from low dose 10 mg to high dose of Empagliflozin in patients with type 2, specifically, and this data was published last year. specifically to answer the question, can we benefit from increasing the empagliflozin from 10 to 25 milligram, or as we used to say, that no difference between the 10 and the 25, and not to going in much details of the study, but in this study, there has been a significant reduction of fasting blood glucose of A1C when switching from 10 milligram to 25 milligram of empagliflozin. Not only glycemic control, but BMI decreased and the triglycerides significantly decreased. And the conclusion, increasing the dose of empagliflozin from 10 to 25 milligram له good impact على glycemic control, على البادي weight, and على metabolic or cardiometabolic risk factors as well. So for this patient, I am near to the target, and she is on 10-5 fixed dose combination of empagliflozin. It would be a smart idea to shift here to the higher concentration of this combination, giving 25 milligram of empagliflozin with 5 milligram of linagliptin. Mr. Chairman, dear friends, let me conclude that after this journey with the cases, that one size cannot fit all. You decide which is the best regimen based on the characteristics of your patients. And I would place such a single pill combination or a fixed dose combination of empagliflozin with linagliptin في الحاجة كريمة اللي عندها cardiovascular disease وheart failure, and she is already on DPP4 inhibitor. Just replacing the tablet of DPP4 inhibitor with DPP4 inhibitor with SGLT2 inhibitor would help adherence to treatment. الدكتور عادل اللي عنده chronic kidney disease وهو already على DPP4 inhibitor وميتفورمين, you will just replace DPP4 inhibitor with a single pill combination of DPP4 inhibitor and gliflozin. الحاجة سميحة اللي عندها advanced chronic kidney disease and metformin is contraindicated, and she needs a combination SGLT2 inhibitor for renal protection and linagliptin as a safe DPP4 inhibitor, safe blood glucose lowering drug in this patient. And lastly, Rania ما عندهاش لا chronic kidney disease ولا cardiovascular disease, ولكنها newly diagnosed patients eager to lose weight, concerned about hypoglycemia. This patient would benefit from such a combination. Thank you very much for attention.
Dr. Magdy, شكرا كثيرا for your excellent, attractive, informative lecture. ونترك للجمهور للسؤالين. الدكتورة بثينة، تفضلي دكتورة. الدكتورة بثينة ما فيش إلا من هنا.
I have a question regarding I have a question regarding using empagliflozin in patients with a single kidney or with a precious kidney, like after renal transplants. Can you use it?
Excuse me, I didn't hear. Can you say it again, please?
The use of empagliflozin in huh? Okay. Okay. I wanted to ask about the use of empagliflozin in patients with a single kidney or in patients after kidney transplant. Can it be used?
Thank you. Yeah, thank you very much. Very important and practical question. Actually, it's all a matter of renal function profile. Looking at the patient GFR, keeping a close monitoring of GFR after starting the molecule, and keeping an eye on potassium as well. So you can use safely, but with close monitoring. For me, I am monitoring GFR in such patients every 2 weeks after starting the SGLT2 inhibitor and potassium to look at as well every 2 weeks till stabilization of the dose, and then after that by 3 to 6 months to keep monitoring of GFR and keeping an eye on electrolytes as well. So this category should be on SGLT2 inhibitor, but you are right that one should keep close monitoring of GFR specifically in such high-risk patients. Thank you very much.
دكتور الغالي خالد دكتور خالد طبعا. The second question will be from cardiologist doctor.
أهلا وسهلا بحضرتك.
Doctor, thank you very much. Actually, I admire your lecture all the time. My question regarding sometimes patients come to you with UTI. Shall we continue? Shall we stop it? Shall we treat the patient? How you manage?
Thank you very much. Very important and practical question as well. Yes, urinary tract infection is one of the side effects of SGLT2 inhibitors. لا جدال ولا خلاف في هذا. ولكن تعالوا نشوفوا الإيفيدنس. سؤال: هل اليورينري تراكت انفكشن اللي حصلت في كل الراندومايزد كنترول ترايلز with SGLT2 inhibitors سيفير؟ الإجابة معظمها مايلد، معظمها lower urinary tract infection، معظمها easily treatable urinary tract infection. وبالتالي حدوث UTI with a patient on SGLT2 inhibitor بفكر نفسي ان انا مش عايز احرم المريض من البنفيتس of this class عشان حصل cystitis once. So what we should do is to treat the UTI and monitor the patient. If the patient، وده اللي بيحصل في معظم الحالات واعتقد حضراتكم هتوافقوني، ان العيان هيمشي كويس، الكورس is benign. لكن اذا حصل recurrent UTI, severe urinary tract infection, definitely I will stop the drug. ولكن عادة السيناريو بيبقى benign. عادة الموضوع ليس كما كنا نتصور قبل الكلاس دي ما تنزل. كان عندنا كده نايت مير، دي هتزود اليورينري تراكت انفكشن والمريض مش مستحمل يورينري تراكت انفكشن. ولكن الواقع والإيفيدنس قال إنها لو حصلت بتبقى mild, lower and easily treatable urinary tract infection. واكيد البنفيتس of this class اكثر بكثير جدا من risk of having UTI. Thank you very much for the question.
Thanks, well, thank you very much.
بشكر حضرتك جدا.
شكرا كثيرا دكتور، والى مؤتمر قادم ان شاء الله.
ان شاء الله. كان ليا عظيم الشرف والفخر والسعاده ان انا اكون مع حضراتكم النهارده. دايما في تقدم وبالتوفيق دايما، وكل سنه وانتم طيبين.